Good evening, everyone, and welcome to our talk on blood products and transfusion triggers. My name is Monique, and once again, thank you for joining me. So, I wanted to just start us off with two important definitions that we'll be referring to quite frequently throughout the presentation. That being a blood product typically is referred to as a substance that is derived from human blood, including whole blood and other blood components. And a transfusion trigger is typically the value of hemoglobin below which a red blood cell transfusion is indicated. So the dates that you're currently seeing on your screen are all dates that were important in the history of blood products and transfusion, and I just wanted to go through a few of the important ones. In 1628, a physician, William Harvey, discovered the circulation of blood. Then we fast forward to the year 1818, where an obstetrician actually performed the first successful transfusion of human blood to a patient for the treatment of postpartum hemorrhage. We then fast forward to 1901, where the first 3 human blood groups were discovered, to 1907, where the concept of cross-matching was suggested to exclude incompatibility. We then fast forward all the way to 1970, where in the United States, the blood banks moved towards an all-volunteer blood donor system, to an important year, 1992, where donor blood was beginning to be tested for HIV. The World Health Organization has committed itself to stating that safe, effective, and quality assured blood products contribute significantly to improving and saving lives. It contributes to reductions in child mortality, improving maternal health, which are all important millennial and sustainable development goals, improving life expectancy and the quality of life, as well as supporting complex medical conditions such as your life-threatening genetic disorders like your hemophilias, your thalassemias, or your acquired conditions such as your malignancies, complex surgical procedures, including ones for trauma and transplantation. Just a quick note on the physiology of transfusion. Essentially, when there is massive blood loss and patients go into shock, they develop a tachycardia, which results in subsequent hypoperfusion of tissues with subsequent lack of cellular oxygen delivery, which is what we refer to as ischemia. A transfusion is then typically required in order to replenish the lost components as well as to restore hemodynamic stability and the tissue oxygen supply. That is all explained by the long equation that we see here. This equation basically refers to your whole body oxygen delivery, which is the DO2, is equal to what is known as the arterial oxygen concentration, defined by your hemoglobin concentration multiplied by the oxygen carrying capacity of hemoglobin, which is this coefficient of 1.34, multiplied by the arterial oxygen saturation, added to what is the plasma oxygen dissolution coefficient at body temperature, and the partial pressure of oxygen or arterial blood. All of this, like I said, is referred to as our arterial oxygen content multiplied by your cardiac output, which gives us the whole body delivery of oxygen. An important note on lactate. So the lactate is essentially when our bodies go into an ischemic state as a result of reduced cellular oxygen delivery. Lactate is produced as a byproduct of anaerobic metabolism and is therefore used as an important marker in the demand and the availability of oxygen and is therefore able to be used as a marker in resuscitation efforts. So we are all familiar with our blood, ABO blood grouping system, A, B, and O respectively. Each of these groups have got a positive and a negative element to them, And just important to point out, your AB positive blood in groupings, they are able to receive blood from all the other blood groups. However, they are only able to donate to other AB positive blood groups. Your O negative blood groups are able to donate blood to all other blood groups, but are only able to receive blood from your other O negative individuals. Moving along, I just want us to go briefly through the different type of blood products that we have available. So in terms of blood products, we've got red cell concentrate, leukodepleted red cell concentrate, the pediatric variant thereof, as well as whole blood. In terms of our platelets, we've got concentrated platelets, which can be pooled. We've got leukodepleted platelets, as well as the pediatric variant thereof. We also have plasma products, which refer to our cryoprecipitate, our fresh frozen plasma, as well as cryopoor FFPs. Starting off with whole blood. Whole blood typically consists of red blood cells, white blood cells, platelets immersed in a plasma. It's usually indicated in life-threatening hemorrhagic conditions where the oxygen carrying capacity is reduced, coagulation factors are necessary, platelets and volume expansion is needed. Whole blood ideally comes from a single donor. It's also indicated for use in exchange transfusions in our pediatric population and is also used during auto-transfusion procedures. These are used in patients where there has been massive hemorrhage, or during surgery, blood has been collected in like a cell saver, and the same blood that the patient has lost is then transfused back to them. Our red cell concentrate is also referred to as a packed red blood cells. So in terms of the preparation, by a process of centrifusion, red blood cells are separated from whole blood, and this is usually indicated when we need to augment the delivery of oxygen as a result of low hemoglobin. So this will be for our anemic patients when there's acute blood loss. Leukodepleted red blood cells, this refers to red cell concentrate in which the leukocytes have been removed using leukofilters or apheretic devices, and this is just to reduce the occurrence of febrile non-hemolytic transfusion reactions or the transmission of leukotropic viruses. Platelet products are administered in a bid to prevent bleeding or to stop ongoing bleeding, and again by a process of centrifusion. Platelets are separated from donated whole blood. An important note on platelets is that when we say that platelets are pooled, we refer to platelets that are derived from about 4 or 6 donors. And this is done in order to achieve therapeutic doses because the concentration of platelets that's derived from an individual donor might be too low. They can also be obtained by a process of apheresis when you've got individuals, for example, who have got conditions such as a essential thrombocytosis. It's just a non-surgical method of reducing the quantity of platelets in the blood. Plasma products. So plasma products, we will start off with our fresh frozen plasma. This is obtained from the liquid portion of whole blood and it contains clotting factors. It's typically administered to individuals who have got low blood clotting factors, patients who are on warfarin, who have been over-warfarinized, their iron are very high, then they are bleeding. Also, individuals who have got low levels of other blood proteins, individuals who are facing coagulopathy associated with trauma, and who are going into DIC. An important note on FDPs. FDPs refer to freeze-dried plasma. And this is essentially plasma in which the water has been removed by a process of freeze drying, which leaves the plasma and the clotting proteins in a dried, stable state. and this is stored at room temperature and is then rehydrated with sterile saline, and then this is then transfused to the patients also using a bloodline. It's an extremely cost-effective, useful alternative in situations where we might not be able to access FFPs rapidly, where there is no blood bank that is available, or when you are in a resuscitation and your patient is not responding to any fluids, there's a worsening lactate or worsening base excess, and FTPs are available, they are a useful alternative. The last note on plasma products refers to cryoprecipitate. So these are also plasma derived, and compared to your FFPs, they're just a more highly concentrated source of fibrinogen, and they help to prevent or control bleeding in people whose own blood does not clot properly. So this will be your patients with your hemophilias or your von Willebrand's disease, so all of your genetic blood clotting disorders. This is the form that we used to order our blood and our blood products, and in the bottom left-hand corner, that's where you'll see most of the options which I've just discussed with you. Moving along to our transfusion triggers. When it comes to our transfusion triggers, these depend on several variables. Is our patient bleeding or not? Is our patient hemodynamically stable or not? Have they just endured a massive trauma? What are the comorbidities that are driving their hemoglobin? And most importantly, probably what are the patient's wishes? It's also important to remember that a clinical assessment is always necessary, because a lot of the time patients who need to be transfused are not always losing blood acutely, and therefore evidence-based correlations are important to consider. It's important to remember that anemia is not well tolerated by critically ill patients, and these patients are usually transfused at a hemoglobin below 7 and maintained. You aim to maintain the hemoglobin between 7 and 9. Patients who are in septic shock, according to the TRIS trial that was done in 2014, they looked and compared the difference between transfusing patients at an HB of 7 versus at an HB of 9, and found that depending on the trigger, yes, they might receive fewer transfusion. However, after 90 days, the outcome sort of evens out in terms of mortality, the need for life support going forward. Our platelets, so normally our platelets range between about 186 to 454, and we'd like to maintain them between 30 to 50 in terms of patients who are bleeding acutely or are undergoing trauma acutely. For patients who are bleeding or undergoing major surgery, we'd like to maintain our platelets above 50. And for patients who've got like major brain bleeds, we'd like to maintain our platelets above 100. Like we've mentioned before, our FFPs or FCPs, these are administered to patients who've got massive hemorrhage, if they're actively bleeding and they've been over-warfarinized, for example. And as far as transfusion and trauma is concerned, so usually in trauma patients, the blood loss is uncontrolled and there's usually massive bleeding. And as we've mentioned earlier, even the World Health Organization has stated that this is a major preventable cause of death. And as a result of this, several hospitals and institutions have got what we refer to as a massive transfusion protocol, which differs by region, which differs by hospital. So during a massive transfusion protocol, it typically refers to having to replace more than one blood volume over the course of 24 hours, which in adults would be more than 70 moles per kg. In our pediatric population, more than 40 moles per kg, or it could refer to having to replace more than 50% of a blood volume over a period of 4 hours. So typically a massive transfusion protocol is activated in your critically bleeding patients who require massive transfusion. So when there's a massive trauma or like an upper GI bleed, your patient is not responding to fluid resuscitation, on repeated blood gases, there's a worsening base excess, an increase in the lactate, there's ongoing bleeding requiring surgery, or there's major obstetric or gynecological bleeding as a result of ectopic pregnancies, antepartum hemorrhage, or postpartum hemorrhage. Like I've mentioned, transfusion protocols differ by centers, and I've had a look at the transfusion protocol that's being used at Healing Joseph. So we usually start with 2 units of red blood cells and 2 units of FTPs or FFPs. If there's a repeat blood gas or resuscitation and there's ongoing bleeding, worsening base excess or increase in lactate, we go to 4 units of red blood cells, 4 units of FTPs, FFPs. There's still ongoing bleeding, still worsening lactate and base excess, you go to 4 red blood cells, 4 FTPs, you add cryoprecipitate and pool platelets. This process is typically repeated until the patient becomes stable, the patient is able to go to theatre, or the patient improves clinically. Just wanted to mention a quick note on the women trial that was conducted in 2017. So it looked at the effect of early administration of tranexamic acid, which we know as typically a cyclocapron, on the mortality and the rates of hysterectomies and other morbidities in women who had got postpartum hemorrhage. So it is widely known that postpartum hemorrhage is a leading cause of maternal death worldwide. And it's also known that tranexamic acid in trauma, when administered within the first 3 hours, also reduced the deaths as a result of bleeding. So they did what was called a randomized, double-blinded, placebo-controlled trial in women who were 16 and older who were having normal vaginal deliveries or cesarean sections and who had PPH. Essentially, what they found was that death as a result of bleeding reduced, yes, but the rate of hysterectomies and other adverse events such as your pulmonary emboli did not differ significantly. And they concluded that cyclocapron does indeed reduce death as a result of bleeding and should be given as soon as possible following the onset of bleeding. Just a quick note on transfusion reactions. So these are potentially adverse signs or symptoms that occur following the initiation of any transfusion of blood or blood products. These may be acute, which occur during or shortly after initiation of transfusion, up to 24 hours. And they range from being mild to severe, so you can have allergic rhinitis, urticaria, all the way to something like a transfusion-associated lung injury. Your delayed reactions, these occur days to weeks following a transfusion, such as the onset of a hyperbilirubinemia. Immunologically driven transfusion reactions include, like I mentioned, your transfusion-associated lung injuries or post-transfusion purpura, and the non-immunological mediated ones include like hypotension and the transmission of bloodborne illnesses such as your CMV, malaria, or HIV. So just in terms of a quick approach to a transfusion reaction, so initially we slow the transfusion. When a transfusion reaction is noted, you can stop the transfusion and administer an antihistamine and monitor the patient. Should the patient improve, you can opt to continue the transfusion depending on the severity of the reaction that the patient had. If, however, it does not improve, you stop the transfusion completely, replace the IV set, run a liter of normal saline through, send the sample to which the patient reacted along with patient's blood samples to the lab, and manage symptomatically as you would. If still there's no improvement or your patient goes into shock or develops a transfusion-associated lung injury, we take our emergency ABCDE approach and we observe for hemoglobinuria and we manage accordingly. Thank you all for joining this evening. I hope you have enjoyed my talk.
Thank you, Monique. It was awesome. And thank you very much for coming and presenting for us. Are there any questions or any comments from the people who joined the teaching? think you're off the hook, Monique. Awesome. Thank you so much.
Thank you so much for joining, guys.
Please remember to record and save it to your computer.